Dear friends, we are continuing our surgical special today. As you must have already seen, we had very important surgical topics covered today. In the first session, we discussed the basic principles and types of dressing for wounds. This topic was addressed by Dr. Pradeep Garg, who is the professor of surgery at Postgraduate Institute of Medical Sciences, Rohtak. After that, we had a round in which we discussed basic principles and types of suturing. This was this talk was given by Dr. Rajesh Gudara, who is an associate professor at the Postgraduate Institute of Medical Sciences. I would again introduce our panelist we have for our third session. To my right is Dr. Rajesh Gudara, who has just talked about how to address the issue of suturing, and to my left is Dr. Shyam Singla, who is a senior professor in general surgery at the Postgraduate Institute of Medical Sciences, Rohtak. Dr. Shyam Singla would be talking on basic principles of postoperative care, which is a very important and a key issue in surgical practice. Meanwhile, friends, let me tell you that our next topic for today's discussion would be safety and sterilization in surgical practice. Obviously, another very important and a pivotal topic, and common surgical procedures in wards. So, these are the topics which will be discussed today. The next week, we have an orthopedic special coming up. I'll just briefly announce these topics so that those orthopedic students would benefit from this. The first of the topic in orthopedic special, which is next week, would be basic principles of reduction in common fractures. This will be followed by a discussion in basic principles of reduction in common dislocations. Then we have basic therapeutic procedures. The fourth session would be on basic principles and types of physiotherapy techniques which are useful in orthopedics. And finally, we'll have an orthopedic session on basic principles in the management of arthritis. Well, today for Delhi students, we have a radio conferencing also going on. This will be between 5 to 6 p.m. This can be heard on FM Gyanvani at 105.6 megahertz, and the topic for today is preparing for ward rounds for surgery. So those Delhi students can benefit from a radio conferencing facility also. So let us continue with our teleconferencing, and I would invite Dr. Shyam Singla to speak on basic principles of postoperative care. Dr. Shyam Singla.
Good afternoon and welcome to this topic, Principles of Postoperative Care. Friends, as you will appreciate, caring a patient of surgery involves preoperative, operative and postoperative care. A good surgeon or a good physician is that who looks after the patient much more in postoperative period than before or during surgery. Any successful surgery, in fact, is ultimate the result of post-op care. We have many friends who do best of surgeries on earth, but ultimately the patient goes unsatisfied, probably because he was not looked after well in the postoperative period. Therefore, there is no denying of the fact that a person who can do a very good post-op care will have the best possible results of whatever surgery he is doing. Now we come to the fact why at all there is need of post-op care. What is the aim? Why at all should be knowing about post-op care? The aim of post-op care is to enable the patient to return to a pain-free and independent life as soon as possible after surgery. We know when we operate upon a patient, the post-operative period may not be all that nice as probably the patient expected. There is pain, patient is not able to move freely, is not able to eat whatever he likes to, he's asked not to take so many things. So therefore this period of post-op is not comfortable, not to his choice. Hence, to make this patient able to be near normal as early as possible. That is the primary aim of any post-op care. Now, what are the principles? After all, this post-op care has to be based on certain issues, based on some facts. First and the foremost is provide him physiological support. Now, once the patient has been operated, he is not only harmed physically, his physiology also changes. Therefore, he will need physical support in terms of helping him get up, helping him take side, and the physiological homeostasis which has been disturbed because of surgery in terms of not able to take oral, not able to pass urine himself. So all these physiological disturbances which have occurred in the homeostasis, they all need support, and which is one of the primary principle of post-op care. Secondly, give him adequate pain relief. Pain is never pleasant. Any patient coming to you for surgery, the first question is how painful it's going to be. If we assure him that's going to be pain-free, acceptance of surgery by him and decision making becomes more comfortable. Therefore, give him adequate pain relief, because pain by itself changes the physiology, changes the homeostasis of the patient, changes are produced in platelet aggregations, in resistance of the patient. Therefore, it is necessary that pain must be relieved. Thirdly, regularly review the treatment plan. Quite often one sees that you write down the treatment on a case sheet and then forget about it. We know that this person is a physiological person, he is a living being, he has a system which changes every day, changes because of drugs, changes because of the pathology as an operation which we have produced. Therefore, his treatment needs to be reviewed regularly, it needs to be changed regularly depending upon the requirements of the patient. Fourth most important principle is anticipate and take early action on complications. And this is only possible if we are reviewing the patient time and again. A good surgeon will anticipate a complication and take early action before it's really either occurs, or if it occurs, he catches it so early that he does not allow it to get it spoiled further. Therefore, always anticipate that with this surgery, these are the complications which are possible, and accordingly take a very early action. Maintain a good team communication. One has observed many times that a patient lands in emergency or at your clinic or in a hospital. He is seen by a resident or the first doctor in contact. He thinks that he has a burst appendix. Now, interestingly, down the line and upwards, nobody bothers to touch the abdomen. Everybody starts believing it's burst abdomen. The only communication they have is that he has said there is burst abdomen. Maintain a communication which is same starting from top to bottom, so that patient does not get different answers for the same question. Suppose a patient says, can I take oral today? Now, one of the person who visits him says, okay, you can take oral. Subsequently, another surgeon visits him, he says, don't take oral. So this is a very poor communication among the team. The whole team must communicate, must fix what is to be told to the patient, what is not to be told to the patient, whether he can take oral, whether he can sit up, etc., etc. Why monitor? Why there should be monitoring? We always talk of that there should be post-op monitoring. After all, what is the need? The need is we need to identify problem early so that they are nipped in the bud. Now, if the problem is allowed to linger on, the problem may become an irreversible, untreatable problem. Therefore, a wise man will do at the earliest, identify at the earliest, and nip it in the bud. Why review at regular intervals? We often speak that there should be regularly reviewing of patients, their charts, reviewing their old discussion, having fresh discussions. Why after all review this? Now, this is required because patient is not a stagnant material. He is a biological material. Changes are occurring constantly in his body because of surgery, because of drugs, because of your treatment. Since condition of the patient keeps changing rapidly, in the immediate postoperative period, Hence, there is need to review it time and again. Review as soon as possible after surgery. That means once the patient shifted from the OT or to the recovery to the ward, as soon as you get time, that should be your first review. And first review generally should focus your attention on his consciousness. Put your hand on the pulse. That will tell you about tachycardia, bradycardia, hypotension, body temperature, and your soothing hand on his hand or on his pulse will boost him up. Also, care needs to be tailored according to the patient needs. All patients are not similar, and we know that patients are not machines. As I repeated time and again, they are a biological material. Therefore, their needs may be different. Each individual has its own problems, and his reaction to a particular problem or to a complication is different. Therefore, the care needs to be tailored according to the patient need. Now, why communicate? Why the team should communicate frequently with each other? As I said earlier, whole of the team should know what is happening to this patient, what is happening to his parameters. They should have same language, they should have same answers, and they should agree to the plan. Suppose the plan is to change the antibiotic, the whole team should agree to it. Because if we have difference of opinion and the patient also knows that they have difference of opinion, the healing of the patient is definitely affected. Therefore, we must communicate, we must agree to the plan for the patient. Now, there is a huge list of postoperative daily checks. What are the various daily checks you will do for these patients? As soon as you visit, greet the patient. Go with a smiling face, say him hello. This does so many things. It might look very simple, but it does so many things. It tells you whether he is conscious or not, whether he is in pain or he is not in pain, is he comfortable or he is not comfortable. At the same time, when you greet him like a friend, he feels that you are his own. Giving this feeling to the patient that you are his own helps healing. General look of the patient. As soon as you go to the bed, just touch him, see towards his face, say him hello. When you do all this, you know whether he is in cyanosis or not, he is in pain or not. By touching him, you know whether he is in shock or not. Therefore, don't miss this. Go to the bed, greet him, touch him. Subsequently, if a patient is there for a long number of days there are chances of pressure sores developing over areas which are under constant pressure, for example, heels and buttocks. Therefore, turn the patients. Don't keep them supine all the time. As a physician, when you visit him, always ask him to move legs, always ask him to take side. This will help him to show all these areas, plus you focus on these areas whether they are developing any bed sore or not. Regarding wounds, we need not check them daily, but surely there are times when the wound must be inspected, and preferably the wound should be inspected by the surgeon himself or when the whole team is present, because seeing the wound time and again by different persons needs multiple change of dressings, which is not a healthy practice. So whenever you suspect infection, fever or frank discharge, always inspect the wound. It's good practice to ask the patient to cough, especially those patients who have undergone a laparotomy, all patients who have gone under a thoracotomy or any thoracic trauma or abdominal trauma. What it all tells you, if a patient is able to cough, means he doesn't have pain. But if he has serious pain, he will not cough. And if he will not cough, there will be retention of sputum and subsequent chest infection. Therefore, this little question or just advice to him that please do cough at times, it tells you on the round itself whether he has pain, whether there is any sputum retention occurring, or he is prone to have a chest infection. In addition to this, have a look on the chart, especially the temperature chart, whether he is running fever or not. Is this fever a low grade fever, something like 99 to 100, maybe for 1 or 2 or 3, 4 days after the operation? Or is it high grade, occurring intermittently? This gives us an idea whether this is a fever as a response to trauma or this is fever because of some infection. Therefore, charting of temperature is very important, and it's a very good guide for the surgeon to find out whether things in the wound are going well or not. Of course, pulse and blood pressure. The basic vitals tell us whether patient is normal as far as his BP is concerned or he is going in shock. Touching the patient here, again I'll stress, will tell you a lot. Urine output, another important parameter, needs to be measured because it's a very good indirect evidence of the hydration status of the patient. A well hydrated patient will produce enough urine provided his kidneys are normal and vice versa. Focus your attention on all the tubes and drains. It is said that these tubes and drains can kill or save a patient. We put so many tubes generally after major surgeries, like a Ryle's tube, maybe a chest tube, maybe an abdominal drain, maybe a Foley's catheter, an IV line. So many tubes have been placed. Each tube is prone to have complications provided it's not being looked after. What material comes out of these tubes needs to be noted. Its color, is it serous-sanguineous, which may be normal? Is it frank blood, for example following a TUR or following a surgery on a major organ, something like liver or spleen? Is it fecal? If it's dark yellowish, needs to be seen under the microscope for vegetable matter. And if it is fecal, you need to think, has it leaked or is there any other collection which you didn't look after? And also the amount. If the drain fluid is not settling, it's not decreasing, you need to bother what is the possible cause. Now this just to focus how do you keep the Ryle's tubes. Now see the first diagram on the left where the patient's neck is turned on the side. The tube is coming out of the nares, and this is the most common position adopted in most of the places, but it's most uncomfortable. Now because of this tube coming from the right nares, patient keeps the neck turned to the right side. It's not comfortable, it's very tiring. Therefore, fix the tube in the midline on the forehead. Now this lady now can turn left and right very comfortably. Now see the bag which I placed intentionally in this photograph near to the head, which of course is never kept near the head, it is always on the bedside. Now this is a negative pressure applied to the Ryle's tube. It will give you two disadvantages. One, the Ryle's tube can get stuck to the stomach because of negative pressure and it may not drain well. Secondly, we will not know whether the stomach is working well or not. So the ideal way to keep a drain, keep a Ryle's tube and monitor is spigot the Ryle's tube, aspirate at regular intervals, maybe 3 hourly, because you may not listen peristalsis which might have started, stomach might have started functioning, but you are unnecessarily draining out very important fluid which is rich in salts and electrolytes. Therefore, if you do not find enough aspirate at 3-hour aspirations, please remove the Ryle's tube, just don't keep it in. We are losing very precious fluid containing high amount of electrolytes. Now there are some other problems which need immediate post-op care. For example, difficulty in breathing. All upper abdominal incisions and all thoracic surgeries are going to produce difficulty in the breathing in the postoperative period. Now one of the important factor for producing difficulty in breathing in these individuals is pain. If you are able to relieve pain of these patients, all complications subsequent to difficulty in breathing will be looked after. If there is pain, there is difficulty in breathing, there is going to be inability to cough. And if the patient does not cough, he is going to retain secretions. Now if secretions are retained, it might lead to pneumonitis. If we are not able to expand our alveoli because of improper or shallow breathing, it will lead to atelectasis, hence poor oxygen transfer. So a patient who was not supposed to go in hypoxemia is going to hypoxemia because we did not bother to relieve his pain well in time. Patient is unable to take oral drugs, therefore he needs support by IV line and by IV drugs. Temperature regulation. Patients who are exposed to the OT atmosphere for a long time, say laparotomy is going on for hours together, where warmers are not provided or the theatre staff is not bothered about the temperature, these patients are prone to get hypothermia, especially liver trauma patients. Prolonged surgeries, they are likely to go to hypothermia. Therefore, as soon as patient is transferred, please touch the skin again to see whether patient is near normothermic or not. If not, there is need to warm. Whatever fluids you are giving by IV line in hospitals which are not air conditioned, where the recovery rooms are not air conditioned, in cold season, please do not infuse the fluid as such. Warm these fluids, warm the blood, then only give IV. Now these patients, because of trauma they have undergone, they are susceptible to infection. They are also susceptible to infection because some wounds have been created. Therefore, you need to look after these patients that they don't get infection. Also, the problem which arises in these patients is the inability to manage fluid and electrolyte balances. Because they may be vomiting, they might be losing through the Ryle's tube, they may develop diarrheas, they might have fecal fistulae. So they are not able to manage themselves the fluid and electrolyte balances. Therefore, one needs to frequently monitor the sodium potassium levels and the hydration of these individuals. Now coming again to the temperature chart. Short period low grade pyrexia, which is not common following surgeries, it just needs to be observed. There is no need to create panicky to the individual or to yourself. Just observe a low grade pyrexia. But if it is a persistent pyrexia or it becomes a high level pyrexia, then we need to have a septic screen done. And this involves examination of the chest and an X-ray of the chest for any pneumonitis developing or any infection in the lung. We do urine examination, cells, microscope, wound examination, which is another source of fever. If we find there is growth redness, edema or frank purulent discharge, I think there is need to open one stitch and drain out the dirty material. Similarly, if there is persistent fever, one needs to do blood culture. Quite often when the patient is on antibiotics, one may not be able to achieve a positive culture. In that case, one might incubate longer and incubate more amount of blood. Thrombophlebitis, very important cause of fever, and this is not less common these days because of the